let's make a cut here and use the last minute in this section simply to discuss the intralesional approaches. There is so many clinical trial and data out. It's confusing for those who are not the experts in this field. So T-VEC, Merck has an established rule meanwhile, and it's approved as single agent, but we are waiting for data from a randomized clinical trial, namely the MasterKey 265 trial, which is using pembro plus minus T-VEC.
Maybe explain what is T-VEC again.
Yep.
Yeah, so this whole concept of oncolysis is an interesting concept, and whether you use T-VEC or other viruses or other agents to stimulate a local response that can initiate a systemic immune response is really an interesting concept, and in theory makes sense to combine these approaches with anti-PD-1 because they could, by theoretically, can be synergistic with each other, that you increase or you change the tumor microenvironment and you increase the expression of PD-L1 and increase T-cell infiltration into the tumor that can lend itself to a better response rate with the backbone of using anti-PD-1. So the MasterKey trial, so you know that, so T-VEC as a single agent is approved in the US and also in Europe. Different kind of label, but both approved, approved by both agencies. But in reality, it's probably a limited number of patients that we would do monotherapy. It's for patients who have relatively long disease-free intervals, pretty indolent course, have local and in-transit metastases, and I think those patients, if they have a lot of other underlying comorbidities, you could do single-agent T-VEC and have really excellent responses and very good control. But the future of this is the combination. So the MasterKey is a randomized trial of single-agent PD-1, pembrolizumab in particular, versus the combination of T-VEC and PD-1, assuming that they have injectable lesions. That trial, that accrual has been complete. The phase 1b trial, I think, has been published, showing a very nice response rate. I think 62%. It's a small number of patients, I think 18 or 19 patients, and had some really interesting translational information showing that you can increase PD-L1 expression, you can increase gamma interferon expression, and you can also increase CD8 infiltration of T cells into the tumor. So we're looking forward to the long-term results of that particular trial, and I think it's a paradigm that we're going to see, particularly in patients who develop resistance to PD-1, that the addition of an intralesional therapy or an oncolytic therapy can hopefully change a non-responder into a responder.
So Merrick, now we are coming to the point, because for me the most interesting abstract from this ESMO conference is the one on the PD-1 refractory patients, which use the toll-like receptor 9 agonist, IMO 2125, with a cryptic name for, at least for a German tongue, it's difficult. Tilzotolimod, you know, tilzotolimod, is that the right pronunciation in the US as well?
So I don't know, is that harder than talimogene laherparepvec?
Yes, but I'm used to it now.
You're used to it.
IMO 2125 rolls off the tongue much more easily.
Okay, good. Yeah. Okay, because this is an interesting study because it was a combo of ipilimumab, which we would be likely to give in second line anyway, and then combined with an intralesional agent. Is anyone on the table willing to give a comment on this clinical trial results?
Oh, I mean, absolutely. So I think that this is a paradigm that we're going to see building out further. So in this population, using, again, an injectable synthetic toll-like receptor 9 agonist, which is a molecule that is part of the normal virus sensing machinery in your body that will drive the development of an immune response. And here you've put it directly in the tumor to try to drive that response. In combination with ipilimumab, and they saw that even in PD-1 refractory tumors, they were getting a 20 to 30% response rate. They really did look beneficial out over a long period of time. And I guess the reason I want to jump in and be so excited about this is that they're not the only company with TLR9s, and that's not the only node downstream within the type 1 interferon pathway. And so there are molecules, other TLRs, as well as STING agonists, RIG-I agonists, and so on and so forth, that are going to be very, very interesting as they kind of come forward here in the future to see how can we sort of capture patients back after they've had progression on initial treatment with PD-1 and maybe CTLA-4.
So one very quick question, I hope for a very quick response in the interest of time, you know. And this is, do you see any advantage of these STING and toll-like receptor agonists, you know, one over the other one? Is there a clear
I think it's too early to
difference?
say yet, and I think these pathways are very similar. They're not exactly the same. We don't understand them well enough to say one would be better than the other. So my guess is that in the end, it will come down to pharmacokinetic and pharmacodynamic properties. Which drug is actually the best drug is probably going to make a difference.
And I think we need to make 2 points. First, for the evaluation, I think it's very important that when we evaluate differently the injected and the non-injected lesions. Because that
Absolutely.
was a sort of mix, obscure,
Yep.
and it was discrediting the field.
Yep.
And second,
Agreed.
I think we also have to work, it's not so easy to inject, like the quantity. If you inject too much of STING agonists, for example, then you have the opposite effect. So it really has to be thought. We have to be smart using that. And also we have to develop very good relationship with our interventionist radiologists so that they can go and inject well, and not only in the skin and the lymph node, but other organs.
And I have to say, the injectable therapies, again, there's something very intrinsically logical about this approach. And again, I think the results look quite promising. I think the part that is interesting is the idea, though, eventually we're going to have to compare this to systemic administration of therapy. And again, thinking again about Jason's report at ASCO last year with, systemic IPI, plus PD-1 therapy, how will that combine? It's essentially what is the right thing to combine with ipilimumab in the second-line setting after PD-1. And, to this point, it is one of the interesting parts. We talk about many of these things. We still haven't really compared things head-to-head. And I think and it's a good thing to get to the point of saying that, yes, we're seeing enough activity that it's worth doing those types of trials.
But here's the challenge, though, is registration, because it's going to be very difficult for the FDA to figure out a way to get these therapies registered and approved, because no one's going to use these therapies as monotherapy. So there's not really space to approve TLR9 as monotherapy. They're going to have to be approved based on combination therapy, and that's going to be a challenge. And
It's a challenge, but it's
Yeah.
doable.
No,
I mean, so
agreed.
cobimetinib was only approved in the U.S. in combination with vemurafenib, right? So it's not like there's no precedent.